3 guests today, and the first one is Dr. Dennis Court from the Medical Protection Society. And Dennis, I've heard this lovely expression that you should respect the old when you're young, the weak when you're strong, and confess your faults when you're wrong, because one day you're going to be old, weak and wrong, and I'm looking forward to that day. And I understand that your brief was to talk about managing adverse outcomes for the Medical Protection Society, and yeah, mindful of the fact you had a whole morning to talk about, but certainly I think as doctors we're all very nervous about that famous phone call, you've had a complaint, and I think that brings us all to our knees and makes us sweat in places we shouldn't. So would you like to tell us the highlights of what the message you want to get across?
Yes, certainly. In fact, thanks for the opportunity, and it's delightful to be here. And basically, you know, when the reality is in healthcare things do go wrong. It's not like flying on an airplane where you know it's a healthy airplane, except once in 2 million times. With healthcare, people aren't well, and that's why they seek our assistance. So sometimes things will go wrong with the care we provide, not because necessarily we've done anything wrong, but because it's a complex situation where treatments aren't always perfect. Now, in particular situations where the outcome is a serious adverse event for a patient, I think my basic message really is that's a very difficult situation for the patient, but also for the doctor.
What type of serious adverse events are we looking at?
Well, if for example, a patient requires extra surgery because something hasn't worked out, or their recovery from a procedure has been affected by, say, wound infection or whatever, you know, even from a skin mold being taken off, if they end up with cellulitis, that clearly has a huge impact for the patient, where they won't get back to work as quickly, they're not sure how they're going to deal with their family situation and so on. The problem for the doctor is not only do we have to assist the patient through that time, but we also sometimes have an emotional reaction to that situation ourselves. So not only are we dealing with a vulnerable patient, a patient who's feeling vulnerable, but we're feeling a degree of vulnerability ourselves too. Will this end up being a complaint? You know, have I done something wrong? And most often, you know, we haven't. Most adverse outcomes are properly given care with a complication. So I guess my basic message is that we need to make sure we look after our own emotional situation, our own emotional consequences of those situations, as well as being available to assist the patient through a complex and difficult time for them. And what we have found at MPS is the best way to do that is almost with a mnemonic. I mean, there's learning to go around that mnemonic, but there's a particular model. It's almost like the ABC of resuscitation. I know we've moved on a bit from that, but you know, when you walked into your first resuscitation, unless you remember the first thing you've got to do is airway, the resuscitation simply didn't go well. And with adverse outcomes, the first thing that has to happen is, again, an A. It's acknowledgement. We have to acknowledge to the patient that there has been a problem. We have to convey empathy. We have to say that we regret the situation we're in. You have to say sorry to them. Unless we do those simple things first, the patient won't be open to what we suggest about how to fix the situation they're in.
This is really important. I think, as you say, I think as doctors it's our mortal fear, and I understand that you're a lawyer, you're a doctor and an obstetrician and a human, and one could argue all four are incompatible, but
totally
you rolled it into one.
Yeah.
And you run workshops on this thing. I know you ran a workshop this morning, and we can see you in action, I think, if they play it for us. So what feedback do you get from your workshops on how
Well, you know, I've got to say that the best feedback I ever got, and the model we have is called the assist model, and it starts with acknowledgement and saying sorry and asking for the patient's story. And the best feedback I ever had, in fact, was a psychiatrist of all people who 5 days after we did this workshop actually contacted me and said, "Dennis, I had a terrible situation yesterday, and I used the assist model and it really went well." Now, the point we're making is that without, you know, because we fear our own outcomes with those conversations, I heard somebody this morning call them the sweaty arm conversations, sweaty armpit conversations. Unless we know how to approach those kinds of conversations, we can't look after our own individual dynamics well enough to actually be able to assist the patient. God, do I really look that bad?
No, you're very good looking.
Okay.
So you were saying assist, that presumably stands for something?
It stands for acknowledge.
Yeah.
Sorry, and that's about expressing, it's not about expressing responsibility necessarily, it's about expressing regret that the patient's in the situation they're in, and then actually asking for them to to give their story as to what it is they're experiencing now, what they did experience when things went wrong for them, providing them with information, and then coming up with solutions in negotiation with them. And I'm not going to tell you what the T is, because I've got to keep something secret. But
that will drag it out to you. You've had the injection before you came on.
Yeah, I did have the truth serum. Yeah, the truth serum. Yeah.
So that'd be superb. So certainly, as doctors, what do we do wrong?
Well, I don't think it's so much a matter of doing something wrong.
But I was more thinking, when something goes wrong, how do we then mishandle it there and after? What mistakes do we make?
I understand.
You're a lawyer.
I understood the question, but no. What I'm trying to say is that it's, unless we get the process right. For example, unless we acknowledge the patient's situation, unless we empathise with them, they won't be ready to hear what our suggestions are to manage their ongoing care. Because what we want to do with their ongoing care is get them from their complication situation to where they would have been if they hadn't got their complication. I mean, that's what we're trying to achieve. And you know, that's the part we're good at, because we have the medical knowledge and we know about evidence-based medical care. We're good at that stuff. What we're not so good at, I am so bold as to say, is getting to the point where the patient is ready to take that stuff on board. Because they are feeling vulnerable, they are starting to think, well, why did this happen? Has a mistake been made? You know, I didn't expect, even if we've said to them, look, there's only 1 chance in 100 of this happening, it's always somebody else it's going to happen to. So when it does happen, when they are the 1 in 100, they have no understanding, you know, why am I the 1 in 100? So they have to be able to, they've got to be empathised with, they've got to have an opportunity to tell what this experience is like for them before they'll have any readiness to take on board our management plan. And that's what it comes down to. So it's really simple communication skills based around a model which has a mnemonic to it, which actually allows us to, gives us a framework which makes us feel capable of dealing with those complex situations.
First class. So that's the patient. I think very often the patients are not as much problem, it's the relatives of the patients which can be particularly malignant.
Yes,
have you any extra advice to give negligent people like myself on how to handle those people?
Well, if it's a situation where it's the relatives that have brought up the issue, I mean, what I've been talking about today is more a patient who comes back to your surgery where they've had a complication. So usually it is the patient. However, sometimes they can have a particularly difficult relative with them, and it's a matter of how do you actually not allow that person to basically undermine what you're trying to achieve there.
First class.
And that can be very difficult.
I'm glad you said that.
Getting them a cup of tea.
That's first-class advice, and I think we'll grab a coffee afterwards. Unfortunately, we're just about to run out of time.
Yeah.
Now then, are you going to divulge that tea, or are you going to tell us how we're going to find out what that tea is?
The tea. The tea is
That's
actually
not a cup of tea either.
No, it's not. It's actually, it stands for the word travel. But what it really means is that one of the very important things is to make sure we do travel to our patients. That might be down a corridor, it might be to the next room, it might be whatever. But we mustn't allow our patients to be abandoned in their time of vulnerability. Now, if, for example, someone's got a wound problem, a wound breakdown, we might think we need to see them every 10 days to check that it's healing. The patient might need to be seen twice as often as that because of their sense of needing the relationship, needing the support of the relationship. So it's really about listening to how much the patient needs to see us or have access to us, and accepting the subjectivity of that rather than just being purely objective about, I don't need to see you for another 2 weeks.
Good for you.
Saying, I need to see you in 2 weeks, but if you need to come back before that, that's fine. Please just make an appointment.
Need to know. Unfortunately, talking to travel, I believe you've now got to travel as well.
I believe I've got a plane to catch, and I understand my chance of 1 in 3 million of an adverse outcome on the plane. So I'm pretty happy about that.
God bless you. Look, I appreciate you coming in. Enjoy your flight home.
Thank
you very much indeed. Take care. Thank you. Now then, also yesterday we had the meeting of the Rural Health Alliance, and it's an absolute delight to now introduce to the couch my good friend Joe Scott Jones.
Hi there, Buzz.
Joe, take a seat. Joe, I have heard this expression that Mark Twain said, Give a man a reputation as an early riser and he can sleep until noon. Now then, he obviously wrote that before you came on, because I have no idea how you sleep. You're chairperson of GP Network, you're on the faculty executive, you're a GP in Opetiki, I can never pronounce that. You taught me a new disease, multiple diplomatosis. You've got more letters than the alphabet. And it's very good of you to come here today. And now then, we want to know more about the Rural Health Alliance and how yesterday went. And especially people listening, they might even say, what Rural Health Alliance? We didn't know there was one. So could you tell us about that? And
absolutely, yep, Buzz, and again, thank you very much for giving me the opportunity. The Rural Health Alliance Aotearoa New Zealand, I suppose, arose out of some of that pressure that you talk about, of there being multiple organisations that are involved in the health and well-being of people living in rural communities. You know, for me, the New Zealand Rural General Practice Network, the faculty of the College of GPs, and for others, you know, Rural Women, Dairy New Zealand, Federated Farmers, the New Zealand Institute of Rural Health, various PHOs, and obviously councils, local authorities and so on that have very concerned about the outcomes that they see in their rural communities. So I think the Rural Health Alliance Aotearoa New Zealand, or RHÁNZ, is an organisation whose time has really come. It's what I would call a common ground organisation, bringing together different organisations to seek the common ground where a unified voice moving forward may help to make the work of each individual organisation more effective. So yesterday we had our inaugural meeting. We've launched our organisation.
Congratulations.
Looked at the finances, which are of course are quite difficult, and elected our first board. But probably more importantly, had several presentations about the issues of rural workforce in primary care. Currently, I think there is what can be determined a crisis in rural workforce. From the Rural GP Network figures, we know that 25% of practices that we know of are looking for permanent replacements at the moment, and there's various reasons for that. We heard from Dairy Women New Zealand, who are undertaking a study of health and well-being in rural communities, how rural communities have a higher propensity of obesity and lack of exercise, surprisingly. And of course the issues around cardiovascular disease that might sort of flow on from that. They're also looking, along with Federated Farmers, who gave a presentation, at mental health issues in rural areas, which is a key and I think with our current drought, quite a scary issue really. Each time Federated Farmers, they're collecting amazing data year on year, and are able to say in years where there's been weather crises, there's a spike in the number of men committing suicide in rural areas. And so, you know, heaven knows what's going to happen, you know, with our current drought crisis.
So I suppose it goes two ways. I think on the one hand we've got what can we as GPs get out of the Rural Health Alliance, and I suppose the other side of the coin is how will the Rural Health Alliance in turn help the communities we're looking for. Perhaps we can pick the first one first and we'll come back to the second. So for rural GPs, what are we going to get out of the Rural Health Alliance that hitherto we wouldn't have got?
I think general practice has always been concerned for the outcomes for their populations. We live in those populations. We have friends in those populations. Our kids go to school in those areas, and so you know, the intimacy of general practice with its rural general practice with its community is one of the key features. One of the things that actually attracts people into rural working life in health. And one of the key things that we will get out of RHÁNZ is not only the closer association of the rural community-based organisations and an increased knowledge for them of the issues that we face, and therefore greater strength when we take messages forward to government and to DHBs and PHOs. But we'll also have better penetration into those communities. Dairy Women New Zealand are going out into communities and are organising health and wellbeing days. And they're taking people with them to provide those health and wellbeing services. We can provide them with the staff from the local practices that will then also enhance the relationship of those local people with their local primary care teams. Yeah, I just see growth after growth after growth, really, in terms of what general practice will get out of it. And I think that leads into the second issue, which is what will those organisations get out of RHÁNZ. Just the communication sharing. I was stunned by the amount of information that federated farmers collect about communities. They can show the impact of losing your rural postal service. They can show the impact of losing your school on a range of health issues over a period of time, which is such powerful information. And without that sort of information, you know, we find it really difficult to argue our case.
And I presume there's overseas models as well, are there, which we can learn from? The Australians have got their Rural Health Alliance. How do we compare and contrast to them?
We're in our infancy compared to Australia, and so grateful for the support that we've had from the Rural Health Alliance Australia.
They talked to you yesterday as well, I believe.
Leslie Barkley came over from the Rural Health Alliance yesterday and Australia and talked about some of the challenges, some of the things that they've learned. When we first started talking about this organisation a year ago, we had Jenny May from the Rural Health Alliance Australia, who provided us lots of documentation that we could, I think the word isn't plagiarise, it's leverage from. So that's been really important in us setting up our structures and so on. And one of the key issues for us is about finances and about our relationship with government. This is something in Australia which the government find is incredibly helpful to them in actually doing what they want to do in rural communities. If the Rural Health Alliance really helps them to achieve the goals that they want to achieve for their communities, and we want to show to our government that the same thing can happen here.
I really respect the energy which you and everybody else is putting into it. How can we as rural GPs get on board with this new Rural Health Alliance and make it grow legs and run and mature the way the Australians have?
Read your e-zines that come out from the Rural General Practice Network regularly. Look for the local opportunities that Federated Farmers, Dairy New Zealand and so on may be offering in your community. Be prepared to stand up and take part in those activities. Continue to support the Rural General Practice Network. I think it's an organisation that needs your support, and these sorts of activities wouldn't happen without your membership and without their membership and their support.
First class lot, mate. We really get behind that. We certainly do, and thanks for everything. Now, what we're going to do now is I'm going to ask you to shuffle ever so slightly that way. You're going to be joined by a wonderful partner here, and we also one of the workshops we had today was on wound management, and the fear, I think, of many of us GPs is that we know nothing at all about wound care. The nurses have more than creamed us with their knowledge on that one, and probably one of the leaders is Cathy Hammond, and I'm delighted to bring her to the couch now. Cathy, you've come on through, and Cathy, there's Joe Scott-Jones, and Cathy, grab a seat. It's lovely to see you. And
Hi, Cathy.
Cathy, you're a wound care specialist in Christchurch, and you're also about a centimetre away from becoming a nurse practitioner in your own right. And I had the privilege of going to your workshop this morning, and it was just wonderful. I think probably the top thing which I think us rural GPs need to know is, as regards wound care, what are we doing wrong? You receive referrals from all over the place, and you must cringe and think, oh my God, what are they doing? So what makes you cringe? What makes you think, oh, did these guys ever qualify?
I think the thing that I get most concerned about is how other health professionals will hang on to patients. So I think there is something in all of us that we really want to do our best, and we think that we can actually heal a wound. The body heals the wound, not us. But and so
we can stop it though, I think.
We can, yeah. But I think what happens is, we'll have patients coming in with they've had a wound for like 2 years, and different nurses and doctors have been trying to heal it, but actually they really need to be referred to a specialist unit. So I think the whole thing is the wounds should go on to heal. If they're not healing within 4 weeks, they need to be referred to specialist unit. And the idea of the specialist unit is that they can then do a holistic assessment, see what needs to happen, and then put a plan in place and send them either back to district nurses, to general practice, wherever they need to be.
That's superb. And in fact, there's lots of different therapies we want, and I'm just curious. I think a lot of practitioners are into their own way of doing things. People enjoy alternative medicine, and there are some wacky therapies out there. Some work, some won't. So what wacky therapies don't work? What should we stop doing? What has gone out of date and we shouldn't do?
Oh, right. Certainly, some of the things that we still see, which we really don't want to do, is drying wounds out. There is still a lot of practitioners who think that it's really good to dry the wound in the sun. What happens is the way that the wound heals is it needs to be a moist environment for the cells to move. So drying it out not only will stop the wound healing, but will cause a lot of pain.
Fair point.
So yeah, really important to change that.
And one of the things which made, I think, everybody curl a little bit, and you brought them with you, is larval therapy,
yes.
which
Yes.
this is where Joe gets particularly interested. So could you like to tell us a bit about the larval therapy? I think hitherto known as, well, maggots. Go for
Yes,
it.
yes, it's been around, certainly the Napoleonic Wars they were using it, but it's really come back into its own. Using sterile maggots, they're not sort of the general ones that, you know, we don't want flies just laying eggs on a wound. So we get sterile maggots ordered from, there's one place in New Zealand, in Hutt, and then what we'll do is we'll put those onto the wound, leave them for 2 to 3 days. They will then eat the necrotic tissue. They won't touch any good tissue. So they will eat that away, and then we can just wash them off. Sometimes we have to repeat that several times, but what it does is then you just get the new healthy tissue that can grow. So times that it can be really useful to use this is patients, instead of having, like you might need to send them off to plastic surgeon to have a wound debrided, well, it would be really nice to be able to do that in the community straight away. Sometimes patients might find sharp debridement really uncomfortable. So again, this can be a much more comfortable, pleasant way for patients to have it. And I think it's interesting how you said, you know, sort of like, ooh, it's funny, a lot of patients ask to have it done, and the people who are having a problem with it is not the patients, it tends to be the health professionals.
Oh, I can imagine. I think we've even got a video clip to curl our toes a little bit coming up because they're very small in there, aren't they?
Yes, they're very, very tiny.
You said about them, we'll never see it on screen, but I think, did you show a video at your session this morning where they grow into slightly larger animals, really, don't they?
They grow much. Yeah, I'm not sure if it's coming up or not.
Oh, no, well, that's a good-looking person there talking to us. So
but they come.
We'll see it on video in a very short while.
They're going to show it, yeah.
Now then, just that, I'm pleased we've got Joe here because I'm sure this.
I'm not sure that I'm quite pleased to be here. Actually,
we eat them at the end of the presentation here. But all jokes aside, part of the problem with certainly rural remote medicine is access to care and oh, look, here we are. We've got it. Oh, look at this.
The necrotic tissue and the slough. So you can see how big they grow after just 24 hours. These are 24 hours old, and they're very active, as you can see.
The tyranny of time and distance has been something which has haunted us all. So for rural remote communities, can the Rural Health Alliance help us access better wound care by getting more integration and defragmentation of the services? I'd love to hear you two talk to each other on, can we improve one particular thing, wound care, by virtue of this Rural Health Alliance?
I think that would be a real challenge. I think the key things that we identified yesterday were things we didn't really talk about wound care, but the key things we talked about were things like the loss of a rural bus service and I suppose the resulting crash that might end up with, you know, you've got a 30-seater bus with 70 kids on it now. Would result in several wounds that might need some long-term care. But is there a problem with access for people from rural communities to those specialist services?
I think we're doing a lot of work to try and solve that. Certainly in Canterbury we're doing work with some of the rural practices like Kaikoura. So we have, every 6 months we have a specialist clinic where myself and a plastic surgeon, vascular surgeon go out, meet with the nurses and the doctors, give education and have a clinic. So we're seeing patients, but a lot of what we're trying to do as well is to bring up the knowledge base of the nurses and the doctors.
Yeah, yeah. Is there anything particular about this larval therapy that would be why it would have to be applied by a specialist nurse in a specialist centre?
No, I think it's around making sure people have the access to the education,
yes,
knowing who to use it on, when to use it, how to actually, you know, if you need further advice, how to get in contact with the specialist who can actually just talk to you on the phone.
Yes.
Or you know, and but then you can order it. They come by plane. So they can be flown, they can be couriered, they'll come to your door, you can put them on, and so the patient can have them in their own home.
So where the Rural General Practice Network might fit with that is providing opportunities for education, and with the Rural Health Alliance, it would be around, because I'm surprised that you say that patients are asking for this and that it's the health professionals who are squeamish. I'm a patient as well as a health professional. I think I would be slightly squeamish about having maggots crawling around on my open wounds, and but I suppose the Rural Health Alliance would be an opportunity to talk to people in the communities, in their places of work, about the potential for this sort of therapy, make them aware that it's something that is actually mainstream, and that the practices aren't treating them with something out of the 16th century just because they have that particular bent.
And I suppose that widens it out further than the education to a certain degree. I think certainly I enjoyed your workshop this morning, and there was lots of I never know that sort of things, and I would have guessed that the practitioners, the nurses and the doctors out in the rural community need educating to stop us doing what we're doing wrong, really. I certainly know we touched on this morning, but for example the use of water, tap water in wounds, that's obviously just come up relatively recently. Would you tell us about that, the use of tap water in wounds?
Yeah, we used to use sterile saline always in wounds, but there's been a lot of research done now to show that potable tap water, which means tap water that's fine to drink out of the tap, is absolutely fine to be using on wounds. Wounds are not sterile. When we're talking about, particularly when we're talking about chronic wounds, they're not sterile areas. So, and the other thing that happens when people are irrigating wounds and cleaning wounds is they just tend to clean the actual wound, and what's really important is cleaning the surrounding area, because there's a lot of bacteria on the surrounding area and we have to look after that skin as well. So by getting people into the shower is much better, or making sure that whole area including the wound is washed.
Good on you. Now, actually talking of water, I think that's going to be a luxury which we won't be able to afford for much longer if the drought continues, won't it?
Yes, that's right.
That's what we're going for. Well, unfortunately, my voice is telling me that we're nearly out of time here, but I really appreciate both of you coming, and I'm sorry if I only had a very small snippet of what you were doing. But and Joe, likewise, thank you very much indeed for not only coming here, but all the work you're doing as well. I really appreciate that.
No, it's always a pleasure to talk to you, Buzz.
Bless you, even on camera. That's wonderful. Right. Well, we've got just a few seconds left, but certainly we'll be tuning in tomorrow. Now, tomorrow we've got Chai Chua, the National Director of the National Health Board. Joe Scott Jones, you're visiting us again because you've got nothing else to do, including not sleeping. And finally, we've got a snippet from the Year's Nurses Forum with Deb Bailey and Sharon Hansen. So thank you very much indeed for tuning in. Thank you both very much indeed for coming. And enjoy the rest of the conference, won't you? And I'm looking forward to the social activities which networking all about. God bless you both. Thank you very much.
Thank you.